Aí, vamos!
Tá?
Estamos a dizer aos teus seguidores que começaste o vídeo e
Certo. Mas então, temos ovos aqui. Que caraça. Mas então eu começo e depois a Joe faz isto para o YouTube. É?
depois vai carregar.
E vai para o YouTube. Portanto, esta parte já vai sair no YouTube.
Já está.
Ok.
Wait a minute! Let me sit!
Sit. Okay, let's start. Good morning, class, and welcome to What Would You Do Season 3, like Berta said yesterday. Last 4 months we were very quiet because it was Christmas. Everybody was shopping. No? No? Okay, we just were quiet because we were very busy at the clinic. But we are back with a new season, a new format, new faces, orthodontic faces, prosthodontic faces, oral hygiene faces. We have a lot of new cool news for you. It's recording? Yeah? Okay. So, let's not waste any time because the fans are waiting for us. First of all, let's go to the quiz directly. Just jump into the topic. I post this pic, and this is, again, this is a very tough case in terms of clinical decision. It doesn't mean that our way is the right way. Maybe you have another cool way to solve the case, but we want to show how we solve the case of this lady. This lady appeared with, how do you call this? Separation on number 11. Okay, she's a 73-year-old ASO1 patient. And she had mobility, pain on function. You know, it's one of those teeth that, you know, is just wobbling everywhere and the patient wants a solution. Okay. And what I posted you yesterday was, what would you do in this situation? I know there is, you know, some lack of information. That's on purpose because on Instagram, we cannot put everything. I put you this x-ray, this sagittal view of the bone. As you can see, you have massive bone loss everywhere to the apex of the tooth. Okay, here you see a 3D image of the tooth itself. There's lack of mesial, distal, and buccal bone, and some of the palatal was already also resorbed. Okay, so what would we do? What was the options that I placed here for you? One, immediate implant. Okay, let's just extract the tooth, place an immediate implant. Second one, let's try to save the tooth. Let's do endodontic treatment and let's do periodontal treatment on these two to try to save the tooth. Third option, early implant placement. Just extract the tooth, wait 2 months, and then go with your implant therapy. Or fourth option, just extract the tooth, wait 6 months, and then place the implant. Okay, this is a tough decision. Okay, we also had a lot of discussion around this case. And the results were that almost 70% of you would extract the tooth. Okay? 70% of you would extract the tooth. This is about 30 people, okay, that vote. It's not a big number, but, you know, when they looked at this, they said, just extract the tooth, okay? The way that they deal with the implant is a little bit different. You know, 8% of you said, just do an immediate implant. You just, you know, forget that's separation there. Just go with the implant and pray. You know, 25% of you just said, okay, early implant placement. Just wait 2 months and then do your regenerative procedures. And 38% of you said, just delay it. Okay. Between these two options, you can see there's almost a tie. But 30% of you said, let's try to save the tooth. And I think it's a fair item because we also had the same discussion around either we'd extract or place an implant. In fact, our was higher, the percentage. You know, 50% of us said, let's extract, 50% of us said, let's try to save it. Okay? So let's see how we solve the case. First of all, don't forget, if you want to know more about this, just click on the bell and subscribe our YouTube channel. Okay? Just subscribe. Do you subscribe? No, of course. Just go there, click it, and subscribe. Okay? There's a lot of cool videos of the season 1, season 2, and pre-season of the What Would You Do. Okay? Just go there and click it. And again, it was not me that solved this case. It was the whole team because the discussion around save or extract the tooth is a team approach, just not one brain to solve the case. Okay, so this is our team. Okay, so let's jump into the topic. You have this case here, okay? How do you start to approach this case? First of all, periodontics, okay? So the periodontics on YouTube are, periodontics. Okay, you don't need a probe. If you see the scan, you have almost 15, it's the length of the ruse of attachment loss, clinical attachment loss, and there's bleeding on probing, there's separation on probing, there's everything on probing, okay? There's mobility, you have everything. If you're gonna feel the shard, you have everything. Everything is red line. The second one is occlusion, okay? That's the part where normally you don't spend much time, okay? Is to see the occlusion. How is the occlusion of this lady, okay? Because perio is not working without the prosto part, okay? Or the ortho part, okay? That's why we need an implant dentistry, an implantology. That's why implant dentistry should be a specialty, okay? Implant dentistry should be a specialty, okay? So, because, perio cannot diagnose, or at least is not mindset to diagnose occlusal problems, condyle problems, etc., and the other way around. So in this case, there's obviously a mobility. So the perio guys said, okay, you have here a very aggressive type of periodontitis, okay? It's not a thing of today, okay? We've been following this patient for a lot of years, okay? It's not a patient that just fall down here at the clinic. She has been on regular maintenance protocols, not with you, Pedro, but with Rui, okay? Since forever, okay? She's now 73 years old, and some of the teeth that she had, that we tried to save, just were getting lost along the way, okay? This 73-year-old lady was recently diagnosed with type 2 diabetes, okay? Which can explain the coadjuvant factor for this aggressive localized periodontal disease, okay? And so, either the risk for periodontal disease or the risk of peri-implantitis, if you're going to place an implant, it's extremely high, okay? It's another red line. So it doesn't facilitate here the discussion, should we go for one or the other. But I bring you the initial case, I don't know how many years ago, and you can see that you already had, this was, I think, the first panoramic x-ray that we took when she came to the clinic. This is about, 7 to 8 years. And she had already localized aggressive endoperio lesions, hopeless teeth, fractures. But you can see that the attachment loss was more or less stable, okay? So something happened here during her general health that start to destroying number 11. So it's not that we didn't take care of this. As you can see, we tried to stabilize the periodontal disease. We took out the teeth that were hopeless and we could not save it. But the patient, the general health status of the patient was just degrading. She's a 73-year-old lady with recent diagnosis with diabetes type 2. And you can see here that after some years, okay, here you start to have a problem of the localized aggressive periodontitis, okay? First approach, the oral hygienist said, okay, I'm done. I cannot do more of this. You have to go to the periodontist. When she comes to the periodontist, we do everything. Resective therapies, cleaning, debridement, phase 1, phase 2, phase 3. We recall, we check, we measure the clinical attachment loss. But some years later, she comes and she starts to have a heavy breakdown of the tooth, okay? So in here, after all this periodontal maintenance and, cleaning and motivation, we come to a point where the patient is very disappointed with all of this because the tooth still continues to break down. And she had experience of other implants that we place on the mouth. As you can see, 2 beautiful tissue level implants with the polished color neck for soft tissue, supracrestal. You see here, these implants are here for 3 years, okay? They are stable, the bone is stable. So she knows the advantage of having a dental implant. So here's where it comes an evidence-based approach. We have to stop, speak with the patient, see the different options, and together we have to come out with the treatment plan. And in this case, we decided to go measuring the pros and cons and explaining to the patient the risk of peri-implantitis, she and we decided that it was time for the tooth to go and replace it for a dental implant. And that's what we did, okay? We did an early implant placement, okay? Why? We're not going to use immediate implants here. There's separation, there's infection. It's clearly a red sign for immediate implant placement. And besides that, there's attachment loss of buccal plates, all the red flags are there, so don't go immediate on this case, okay? The decision was between delayed implant placement or early implant placement. I go for the early implant placement because 2 months allows me for the infection to go off, and then I can enter with, with keratinized attachment to close my primary wound for my guided bone regeneration. And that's what we did. So, what was the difficulties here? What was the difficulty here, Berta? How to provisionalize the patient if you're not going for an immediate implant placement, right? Was the first question that she asked me. Dr. Chen, I love you, but this is my central incisor. I cannot walk around without the tooth here. How do I provisionalize? So how do I provisionalize this patient if I'm not going to have an immediate implant here? Options. Berta, first option. And Berta didn't see the presentation, but you saw my presentation? Yes. No. You were there in the surgery, so you shut up. But you were not.
You can put, there are several options.
The most common one.
The most common one is removable prosthesis.
Okay.
You can place
Wait. Removable prosthesis. It's a very nice option, okay? It's a very nice option. It can be an option, okay? But for these anterior cases where you're gonna do bone regeneration, guided bone regeneration, to have something there, impinging the soft tissue is not a great idea. It can be an option, okay? For sure, in some cases, it is. It was not the one that I used. Because the one that normally people say to me is the Maryland Bridge, okay? Like for this example, this is another case where you just simply have, for this kind of defect, you just, glue it on the other teeth, okay? But you can see that these normally, what is the number one problem of these Maryland bridges? They break, okay? They break. We were talking about the other gentleman that we said is going to break, and after 3 days, it breaks, okay? And sometimes, like in this case, aesthetic may be a factor, okay? If the teeth are together, then you can glue it and you can more or less get away with it, okay? Like this case. By the way, this case was that one that we were discussing. You said that this defect will not close. Guess what? It closed. And you know why now? Because it had palatal bone, okay? Now you know, okay? So the Maryland Bridge is an excellent option. And either you can do it with the tooth, or you just CAD-CAM it, like in this situation where Mariana did a wonderful, nice PMMA bridge for a single central incisor, okay? These are different types of Maryland bridges. The thing that you have to be aware is that sometimes they can break, they can detach, and aesthetically sometimes it's challenging, especially in patients where they have diastemas, like this lady over here. So you're not going to do a Maryland bridge with something in the middle. When she smiles, it's completely ugly. So provisionalizing, it's very difficult, okay? Here you have the Maryland bridge with the wings in the back. Other options that we have are the transitory implants, the small diameter implants, that are placed in spaces where the implants are not going, and they can help stabilizing a prosthesis, okay? We call the small diameter implants or temporary implants that are machined implants that are placed without osteotomy and that can hold a provisional, like in this case, where I don't want to load these implants. I did guided bone regeneration, and then the prosthesis can have a little bit of help on this type of procedures, on this type of screw, okay? And this is an example how to provisionalize a guided bone regeneration case, okay? Or, like a wonderful case that we did in the course, you just have a bridge, a traditional bridge, where you use the canines, and this is very common because normally patients have loss of the fore and anterior teeth, and then the prosthesis just is made on the canines, and you stabilize, and you have a fixed provisionalization to not impinge my soft tissue during the guided bone regeneration. Very important. So, what did we do here? Okay? I cannot place an implant, an immediate implant, okay, because there's a lot of separation. There's risk of periimplantitis because she has periodontal disease, and there's separation on the area that will, eventually hit my implant. So what I did in this case, I used a transitional implant, okay? A machine transitional implant, very smooth, with an intermediate abutment made of PICC that is very smooth, that allows me to have a provisionalization of the area while the tissue is healing of the separation. Okay? And how did I do this?
But what is the stability with the infection?
The stability is high because it's on the bone, but it's more buccal than my implant that is going to be behind. And this implant is going, in 2 months, is going to come out and allow me to do my real implant with my guided bone regeneration. Okay?
What's the width?
This is 1.8 millimeter implant. Okay? So what is the idea? The idea is that this part here has to be really smooth. Okay? Because bacteria will not like this part over here. And it has to be very slim. Forget the emergency profile now. It has to be very slim and then come out like this. The tooth has to be completely out of the gum. Okay? So this to heal. This is a stick. Okay? This is a small stick. Okay? See? It's important that you finish all of this and then see the position of this small diameter implant. It's completely away from the position of my final implant, okay? It allows all of this to heal, okay? So in a later stage, I can enter and do my guided bone regeneration, okay? So you have here the separation, you have the insertion of the provisional, and then you have the provisional restoration. In this case, we use the tooth of the patient, okay? It's a technique, doesn't matter, you can use whatever you want. In this case, we use the technique of the tooth of the patient. Okay? And the patient walks away and comes back 8 weeks after. Okay? And we had to enter here because she broke the acrylic from this very smooth cylinder. That's one of the things that can happen. Okay? This is very smooth and sometimes the acrylic does not hold very well. But what you have here is now a very stable position to go and place your final implant. See, there's no separation. The gums looks very nice. It heals beautifully. And now you just go in and you have to open it up and restore the anatomy with guided bone regeneration. But you don't have separation anymore, okay? The separation is clean. So in this case, what we did is open the flap, and you can see here already the transitional implant with connective tissue here. You remove the implant, you see the defect of the periodontal disease here. You see there's attachment loss here, but you still have interproximal bone here and here. And you just go and now you drill on the palatal part. Okay? This was the site of the original implant, and this is the pass of my final implant. You see? On the bone. You see here the position. Now, which implant do I choose? Okay? There's a lot of evidence about the SLA active in type 2 diabetes patients, okay, with the survival rates after 5 years being 99%. Okay? So this type of surface is probably the one that you want to use in this type of type 2 diabetes. Also, you want to have the 2.8 polished color, for soft tissue adherence at this part, okay? That is known in the literature by being the best surface to prevent periimplantitis, especially in high-risk patients, okay? Then you place your implant, then you place your guided bone regeneration, then you place your membrane, okay, collagen membrane, then you suture it up and place the provisional restoration. Here is a PMMA that Mariana painted with the stainings, okay? And here you have the provisional restoration. So this is early implant placement with immediate loading procedure of the final implant itself. And you can see here that after a couple of a couple of weeks, you still have the sutures and everything is healing quite nicely. And the position of the implant, I had the position of the implant. Wait. I had the position of the implant. Wait. Espera aí. Okay. Está gravado? And you have the final image of the implant with the implant into palatal bone and then your guided bone regeneration. Okay. And now this implant is with ISQ levels of 75. So it's really stable for the immediate loading procedure. And so this was the case that we solved like this. For all the reasons that I tried to explain, the rationale about trying to save the tooth, the periodontal disease, the risk of periimplantitis, the health factors of the patient, how to provisionalize, what is the rationale with the prosthodontic procedures about provisionalizing the patient, and especially put the patient into a favorable position where you and the patient can talk about what is the best treatment for them in this situation. We have a question.
So after 8 weeks, you put the tooth in position?
No, it's immediate loading with non-occlusal contacts in centric and eccentric position. Okay, but it was a nice question. Thank you very much, and don't miss next week. Who's going to be? You or you? Orthodontic, what would you do on next Tuesday? Thank you. Viva o Benfica!
Agora, eu vou ter que fazer uma linha da
Vais?